Okay, good afternoon, everyone, and welcome to Renal Grand Rounds. We're delighted to have a VIP speaker today, and I'm going to introduce a VIP introducer, Dr. Jenny Lin.
Okay, it is my distinct pleasure today to introduce today's Renal Grand Round speaker, Dr. Jamie Lin from MD Anderson Cancer Center in Houston. Dr. Lin earned her undergraduate degree at the University of Pennsylvania and her MD at the University of Nebraska. She completed her internal medicine residency at Baylor College of Medicine in Houston, where she first fell in love with podocyte biology under the mentorship of Bill Mitch. She ended up loving the kidneys so much that she decided to become a nephrologist and completed her fellowship at the University of Pennsylvania, back in Philly again, where she was a T32 and then F32 scholar in Larry Holtzman's lab. And in his lab, she was studying the role of ARF6 in nephrin trafficking. And she was also at that time, and still is, a dear friend and great colleague, and she was helping me with my confocal microscopy skills. Being a forward-thinking nephrologist, Dr. Lin saw a future in onconephrology, and she decided to complete a second fellowship because she wanted to be PGY 40 at some point. And she went to MD Anderson to do that fellowship, where she became a Ben Lips Scholar, Research Fellow Scholar, and earned her current KO8 award. In her transition to become an independent investigator, she has pivoted her research endeavors to focus on the mechanisms of immune checkpoint inhibitor-associated nephritis. She has won multiple awards for her abstract presentation and is now the senior author of papers reporting the role of T cells in ICI nephritis, which she will talk about today, and we are delighted to learn more about it. So Dr. Lin, welcome, and the podium is yours.
Thank you so much, Jenny, for that very detailed biography of my life. Thank you, Dr. Quagan, for inviting me to come share some of our research that we've been doing for the last 3 years. I hope that this will be an informative lecture where I'm going to be able to update you on some of the findings that we've seen in immune nephritis, as well as research that's ongoing. So without further ado, the title of my presentation today is Immune Checkpoint Inhibitor-Associated Nephritis, the Epidemiology, Management, and Surveillance. I have no disclosures, but I usually like to break the ice with a fun little cartoon. So the optimist says, "I'm half full," while the pessimist says, "I'm half empty." And of course, the nephrologist says, "This is pee." But no disclosures. So, case presentation, because I wanted to highlight something that we see as nephrologists when we take care of patients with cancer. And so this, I think, makes a good point of why the research is going in the direction that it is today. And so the reason for consult is for acute kidney injury. I'm going to kind of leave out some of the minor details to just kind of hit on the high points. But this is essentially a 70-year-old gentleman with metastatic renal cell cancer. He's on first-line therapy with a checkpoint inhibitor, which is nivolumab, and then also on a tyrosine kinase inhibitor with cabozantinib. He normally has normal function, creatinine at baseline of 0.8 to 1.1, but he's coming in because before their infusions, they always get their labs checked to make sure everything's in line, and his creatinine is 6.9. So this is a dramatic change from previous, and he buys himself a ticket to being admitted to the hospital, and when you talk to him, he says, he's actually doing very well. He had his labs checked about 3 or 4 weeks ago. Everything was good. There were no concerns. He just mentions maybe he had like a URI or allergies or something, but really no fevers, no chills, nausea, vomiting, diarrhea, constipation. So other medical history that is important would be coronary artery disease, hypertension, and hypothyroidism, and the medications that, of course, go with his medical diagnoses: carvedilol, losartan, aspirin, and levo. Exam, he's non-toxic, so not tachycardic, doesn't have any blood pressure problems. There's really nothing on exam that stands out, and there's no rash. So the labs. Labs look okay. His CBC is pretty much at his normal baseline. And his BMP, of course, has some electrolyte disturbances. So, of course, he's got AKI, some hyponatremia, and acidosis. And where's the money at? Well, the urinalysis looks like the specific gravity is 1.005. There's white blood cells present, really no RBCs, no protein. And of course, we get an ultrasound just to make sure there's no evidence of obstruction, nephrolithiasis, and there's none of that. And we just see that the RCC is located in the lower pole of his right kidney. So essentially, a little bit of an abbreviated trend on his creatinine graph where you see that he had essentially normal kidney function, now coming in with a creatinine of about 7. And like any patient that comes and is admitted, we give them IV fluids, the magic. And the magic actually does its job. It improves the creatinine to about a 3.5, which is remarkable since we're really not doing anything but resuscitating him. And a follow-up urinalysis is done, and we see that the UA has changed a bit. So he had evidence of pyuria initially, and now the WBC count has decreased to about 3 per high power field. So the question is, you're coming on service, what do you want to do with this patient? Non-toxic, looking really good, creatinine's getting better, the UA is also markedly getting better. You're your options. And I'm not going to have you pick an option right now, but kidney biopsy for a definitive diagnosis for his AKI. No biopsy, let's go ahead and empirically treat because we're assuming this is immune nephritis. Or do we want to just continue with the current course of IV fluids because he's doing so well with IV fluid resuscitation? Or the other hand is, why not just follow him up as an outpatient? Looks like everything's headed in the right direction. We'll see him in clinic in 1 to 2 weeks and just make sure everything is moving forward. So this is an outline of today's talk. I will briefly go over the mechanism of action of immune checkpoint inhibitors, as well as their off-target side effects, which are collectively termed immune-related adverse events. We'll skim through the epidemiology of renal IREs, management practices for patients who develop acute interstitial nephritis, and then we'll spend a little bit more time on outcomes and immune monitoring. So immune checkpoint inhibitors, immune checkpoints actually are the natural brakes to T cell activation. So if we inhibit these natural brakes, which are CTLA4, PD-1, and PD-L1, you can augment anti-tumor activity and potentially also autoimmunity because you're turning these T cells back on. And there's a plethora of different immune checkpoint inhibitors that are available now and FDA approved, which we will start to see more and more immune checkpoint inhibitors and beyond just these 3 classes. So back in 2011, only one immune checkpoint inhibitor was approved for the treatment of metastatic melanoma. By 2018, there's about 46% of patients with newly diagnosed cancer in the U.S. were eligible for an ICI-based therapy, just, emphasizing and demonstrating the market expansion of the usage of immune checkpoint inhibitor therapy in our oncology world. But the problem still remains is that not all patients are going to respond to treatment, right? And so how do we determine if a patient is responding? Are there markers of response to treatment? One marker that is associated with response to immune checkpoint inhibitor treatment is actually the development of these immune-related adverse events. So when you increase T cell activity, that's non-specific activation. So you hope that they'll target the tumor cells, but it may also target normal, healthy tissues, and those are the presentations of colitis, arthritis, myocarditis, etc. And these are all autoimmune phenomenons associated with immunotherapy. So roughly 60% of patients are going to develop an IRAE. And what we know about the more common IRAEs, which are colitis, the skin findings, as well as the endocrinopathies, is that they've done research to show that these patients actually have improved clinical outcome. So what does that mean? It means that if they develop an IRAE, you want to treat and keep them on the immune checkpoint inhibitor therapy because they're responding. And so that is a big focus of internal medicine at MD Anderson because we're trying to split that hair where we want to continue with the anti-tumor response, but also manage the side effects of these medications. So skin and GI side effects present much more frequently. About 30% of patients will develop some sort of skin finding, and colitis will develop in about 15% of patients. Other IRAs, including nephritis, develops maybe around the 12 to 15 week mark, but very infrequent. So really only 2 to 5% of patients will develop immune nephritis. But even if only 2 to 5% of patients develop immune nephritis, all-cause AKI in patients with cancers, roughly 20%. So what you're trying to actually do is differentiate, is this immune nephritis or is this some other cause of AKI? Kind of like that case that I presented. Does he have immune nephritis from immune checkpoint inhibitor? Does he have nephrotoxicity from his tyrosine kinase inhibitor, or is he just pre-renal? And I keep mentioning immune nephritis, but acute interstitial nephritis is specifically what I am referring to, which is the most common pathology that we see on kidney biopsy. But other pathologies, other inflammatory lesions can also present. So glomerular diseases, whether it be de novo or reactivation of someone with a history of having membranous nephropathy. We can also see vasculitis develop as well. And there are reports of electrolyte abnormalities as well, so really a very broad spectrum of kidney side effects from immune checkpoint therapy. So acute interstitial nephritis, about 80% of the biopsy cases will show AIN, and they're going to have non-specific urinary findings. And this isn't anything new. We know that the UA isn't, the most sensitive or specific test, and it's certainly not diagnostic. So approximately 50 to 60% of patients will have pyuria or WBCs on the urine analysis. But really, to definitively diagnose AIN, we need a biopsy, and in the biopsy, we see inflammatory immune cells infiltrating the cortical interstitium, disrupting the normal architecture of the tubules. You may see some tubular edema as well as tubulitis. And AIN, we know probably more so with drugs associated with AIN, such as proton pump inhibitors, specific antibiotics, and maybe some non-steroidals. And we see that in patients who are on already drugs associated with AIN, that is actually associated with actually developing AIN when they're on immune checkpoint inhibitor therapy. So the spectrum of injury from immune checkpoint inhibitor therapy is really quite broad, because when we reactivate these T cells can then target any renal tubular cells. And so essentially, you can then have lower tolerance to medications that you were previously able to tolerate. Potentially, these T cells recognize a new tumor antigen that cross-reacts with healthy tissue. You can also have acute tubular injury from inflammation, from cytokine-mediated acute tubular necrosis, electrolyte disturbances, and when you have increased T cell activity, you're going to have more or enhanced B cell activation as well, which can lead to B cell maturation, the production of antibodies, and potentially resulting in the development of glomerular nephritis. So really want to focus the talk today on acute interstitial nephritis because it is a predominant pathology that we see on biopsy. So I'm going to go into a little bit about the management of these patients. Management of these patients isn't any different than how we approach a patient with drug-associated AIN. So we stop the offending agent. So if they're on a PPI, non-steroidals, or antibiotics, stop those. We usually, by the time that they come to see us, they have grade 2 or beyond AKI. We'll stop the immune checkpoint inhibitor therapy. And depending on if they get a biopsy, if we really think that this is AIN, they'll start steroid therapy. And some of the work that's been published by, this is the MGH group, showed that there was no difference in renal outcomes if you tapered quickly versus if you did a standard 8 to 10 weeks. And renal recovery following steroid treatment, about 40% will have full recovery, 40% partial recovery, and then about 10 to 20% without any kidney recovery. You can look at this graph in a variety of ways. You could say, oh, look, 40 plus 40 means that about 80% of these patients are going to have improvement of their kidney function. But the other way of looking at this graph is saying, wait, if only 40% have complete renal recovery, that means 60% of the patients never actually recover full kidney function. And we actually want to get that other 60% because these patients need to have their kidney function in order to qualify for cancer treatments. That begs the question, is there a second-line therapy for acute interstitial nephritis treatment? Back in 2021, we published a case series on our experience of using Infliximab for the treatment of very difficult to treat acute interstitial nephritis. And we defined relapse acute interstitial nephritis as those patients that had a diagnostic biopsy showing AIN and that they completed their steroid therapy and about 1 to 2 weeks later had a bump in their creatinine and had redevelopment of AKI that was not attributed to any other cause. The other definition for relapse, which is not technically relapse, but for those patients who were on their steroid therapy but had a difficult time tapering off of prednisone. And so between 2016 to 2020, there were 85 cases that had a biopsy, and out of those 85 cases, 10 of them had infliximab-based therapy used to treat their AIN. So what is infliximab, and what do we know about TNF-alpha and acute interstitial nephritis? Well, infliximab is a monoclonal antibody that targets TNF-alpha. And TNF-alpha is a pleiotropic cytokine that participates in the maintenance of immune homeostasis. So a lot of big words there with lots of syllables, but really it basically does a lot of things, and it's kind of like the Goldilocks phenomenon. You don't want too much, you don't want too little. It can be good and it can be bad, and it just depends on the scenario. And of course, TNF-alpha also plays a role in either pro and being an anti-tumor mediator. What we know about the usage of infliximab is that in patients with autoimmune diseases such as rheumatoid arthritis or psoriatic arthritis or IBD, that it improves their clinical symptoms. And in patients who develop colitis from immune checkpoint inhibitor therapy, they showed that it not only improved their symptom resolution, but they were able to taper steroids faster without negatively impacting their tumor outcomes. Because again, we want to keep that tumor, the anti-tumor activity going while treating the IRAE. And what do we know about it from a kidney perspective? Not a whole lot from the perspective of interstitial nephritis. There are a few case reports that describe the usage for sarcoid and granulomatous interstitial nephritis. And in 2019, the team at Yale identified that TNF-alpha levels were increased in the urine of patients who had drug-associated AIN. So potentially, there is a role for TNF-alpha inhibition in AIN. So of these 10 patients that received infliximab therapy that had already failed or could not come off of steroid therapy, 4 of these patients went on to have complete renal recovery, 4 with partial recovery, and 2 with no recovery. When we dug a little bit deeper to try to understand, what determined renal recovery, we saw that early administration of infliximab, so within a 2-month period of being diagnosed with AIN, was actually associated with improved renal recovery. So those were the 4 patients who had complete renal recovery and 1 patient with partial recovery, but that patient was actually able to come off of dialysis. Versus the late administration of infliximab, they had partial recovery or no recovery. And in the patients who had no recovery at all, the biopsy also showed that they had 40% IFTA or fibrosis already, suggesting that, the biopsy is helpful because if you already have such a large percentage of scar tissue, you would not expect to have full or complete recovery with treatment. And from a cancer perspective, because these are all patients with cancer, and that is also another focus of ours, is that 7 out of 10 of these patients had stable or no evidence of disease or cancer progression, meaning that it didn't, make anti-tumor activity we don't think any less. 3 of these patients ended up having disease progression with progression-free survival of 8 to 20 months. And in these 3 cases, these were the 2 patients who had partial kidney recovery and no kidney recovery. And so what I hope to bring with that case series is that, we're going to stick with the normal regimen of managing these patients with drug AIN, but potentially in difficult to manage cases, we should consider Infliximab therapy for relapsed AIN, patients who are unable to tolerate glucocorticoid side effects, people with type 1 diabetes where the insulin regimen is very complicated, or even as salvage therapy for those patients with partial or no recovery of kidney function where they just need their GFR to be a little bit better to qualify for a phase 1 trial. So what are the outcomes and what is immune monitoring? So what I wanted to highlight today also was that, I spoke about the common IREs, the colitis, the skin rashes, and how those are associated with response to immunotherapy. And how, in those organ systems, there's a really big focus on getting them restarted on immunotherapy. But when you look at our numbers with AIN and nephritis, in this specific study, only 22% of those patients who developed AIN were rechallenged on ICI therapy. So our percentage of patients going back onto immunotherapy is quite low. But what's also important to highlight is that those that redevelop AIN is actually maybe about a fifth of these patients. So it may be worthwhile, and it should be advocated that we should rechallenge these patients. There was another, I think, study published by Shruti and David that also showed that percentage was about 17%. So really about a fifth of patients who have AIN that are rechallenged, redevelop AKI. So majority of people will just go on and tolerate the therapy just fine. So that begs the question, why aren't we rechallenging more patients on immune checkpoint inhibitor therapy if we believe that the development of these IRAs is a marker of anti-tumor response? We haven't really talked about the elephant in the room, which is the kidney biopsy. And so I thought that this cartoon really exemplified how some of us feel about kidney biopsies. But the elephant is saying, sometimes even if I stand in the middle of the room, no one acknowledges me because we really haven't addressed the fundamental problem, or the barrier is that for an AIN diagnosis, we need a kidney biopsy, and that is a barrier. We don't have any available non-invasive AIN diagnostic tests. So when we think about kidney biopsies, we have to remember that these are patients with cancer. And so they have more risk factors for bleeding complications than a patient without cancer because they're likely going to be older in age, have medical comorbidities such as hypertension. In our patient, he had hypertension and CAD and was on aspirin. They may be on a tyrosine kinase inhibitor, which also increases your risk for bleeding, which our patient had in the very beginning. And all of this cumulatively adds up to delays, right? Because we need to optimize these patients. We got to hold the anticoagulation, determine which kidney we're going to biopsy the kidney with the tumor or the other kidney. And that in itself is going to delay the impact of renal recovery because time is tissue. But also, because we need that biopsy, because we need that tissue, we don't have a clear understanding of the pathophysiology of AIN. And that obstructs our ability to improve targeted therapeutic strategies for these patients and for advancing the care for patients who do develop AIN. This is essentially a very general algorithm of how we approach patients who develop acute kidney injury on ICI therapy. We evaluate for reversible causes of AKI. If they happen to recover, they restart ICI therapy and everything is good. But if they don't improve, we continue to hold therapy and we work on getting that kidney biopsy done. And of course, it's time-consuming, delays in treatment, and also it's an invasive procedure for patients who don't have AIN. So remember, 20% of patients are going to develop AKI, but a very small fraction of them actually have AIN, which is a treatable disease, whereas for ATN, we're not going to give them any sort of drug therapeutics. So back in about 2019, right before COVID, a group of us undertook the effort to form this multidisciplinary working group to understand the pathophysiology of ICI-associated nephrotoxicity. And we called this working group I.C.U.P.P, Immune Checkpoint Urine Prognostic Profiling. And you can also pronounce it as I.C.U.P.P. And the focus of that is to improve monitoring, diagnosing, and treating immune nephritis. Our underlying hypothesis is that the immune cells and proteins in the urine are reflective of the kidney immune environment during ICI toxicity. And this isn't too far-fetched of an idea because we know that in other inflammatory kidney diseases such as transplant rejection, lupus nephritis, that they're doing exactly the same work that we're going to embark on. And the goal of this is to identify non-invasive biomarkers that are predictors of AIN that allow us to basically help differentiate those patients that need a biopsy that we can treat versus those that don't need a biopsy and can go on and receive their immunotherapy. Oops, I'm going to skip over how we formed this, but this is essentially the overview of the process. We developed EPIC algorithms to basically identify patients who had developed AKI that were admitted to the hospital that were on ICI therapy as an outpatient. We also changed the way that our clinic funneled patients with AKI on immunotherapy so that we could basically expand our catchment area and enroll these patients into our study, because anytime you're studying a rare disease, one of the limitations is not having enough patients. And so that's how we improved on enrolling our patients into this study. We formed IRB protocols, developed MTAs, and we basically followed the patients throughout their treatment. So we would get baseline urine and blood sample during time of toxicity. And if they underwent a clinically indicated biopsy, we had first dibs on their residual kidney tissue so that we could do that paired analysis. And during the treatment period, we were able to capture longitudinal samples so we could see whether or not an identified biomarker might be something that we could monitor while the patient was going through treatment. And of course, we captured the urine at time of hopefully renal recovery. Because a lot of patients with AIN are going to be treated differently, everyone kind of has their own practice, we also developed an iotox nephritis guidelines that basically outlines what we would recommend for steroids, how often we would recommend for labs to be done, to kind of at least set some sort of baseline for these patients, because it's really difficult to get data that is without a lot of variation, essentially. One of the first questions we asked was a very simple question, because one, we thought that if we could identify or isolate immune cells in the urine, that would at least give us some sort of immediate impact from us seeing these patients clinically. So the first question we asked was, do the immune cells in the urine correlate with the paired kidney biopsy specimens? So this is a patient who I encountered on a Friday afternoon clinic, because that's when all the good stuff comes in. And so he had metastatic melanoma, was on combination therapy, and developed AKI. He not only bought himself a ticket to the hospital, but we were fortunately able to collect his urine sample before steroid treatment. We performed flow cytometric analysis and saw that he had abundant CD3 positive T cells as well as CD19 positive B cells. We were able to further characterize those T cells into CD8 T cells and CD4 T cells. We then performed multiplex immunofluorescence looking at these same immune cell groups, and we saw the same immune cells infiltrating the kidney tissue in this patient with AIN. He responded wonderfully to steroid treatment and had full renal recovery. And post-treatment, we were able to actually capture a sample when he had full renal recovery. And what you can see is actually that those abundant immune cells that were in his urine prior to treatment are really no longer there, or at least in much lower abundance. We did further analysis on these T cells, which I'm not going to show you today, which is T serochronotype analysis, which helped us basically identify whether those T cells infiltrating the kidney were identical to the T cells that we picked up in the urine, and we found a very strong association. But I want to get back to, the point that I've been harping on, which is 20% of patients develop AKI, but you only have 2 or 5% that have AIN. So is it possible that there are distinct mechanisms that underlie the development or the pathophysiology of AIN versus non-AIN? And if we know these differences, can we use it to our advantage? So in the patients that we enrolled, who underwent a diagnostic clinical biopsy, we looked to see what the most common pathologies were in these patients. And what came out was acute interstitial nephritis, acute tubular necrosis, and hypertensive nephrosclerosis, which is not an acute kidney injury, but potentially this is more of a hemodynamic-mediated AKI. We also had some cases of glomerular disease, which we didn't include in this analysis. But for each of these groups, we also had paired specimens, so either paired urine, tissue, and plasma specimens, so that we were able to basically analyze tissue and compare it to these other specimens. We performed bulk RNA sequencing using nanostring to see whether or not we could identify differentially expressed genes that showed up in one pathology group versus another. And so in the first graph, you'll see acute interstitial nephritis versus acute tubular necrosis. What we saw with the top 10 most differentially expressed genes were that cytokines and chemokines, such as CXCL 9, 10, and 11, were the most differentially expressed. We also saw genes that were associated with T and B cell function. We did the same comparison with the hypertensive group, and we also saw very similar findings in that we saw inflammatory chemokines and also markers of AKI. Since we know that AIN is, an immune-mediated kidney pathology, we wanted to better characterize the immune cells that were infiltrating the kidney biopsy. So we analyzed and determined and compared relative immune cell abundances within these three groups. And probably not a surprise to anyone, but we see that there's increased immune cells in the AIN group compared to the hypertensive group and the acute tubular necrosis group. But taking this one step further, in the other IREs, such as colitis, arthritis, and pneumonitis, which are more common, there's more research being done, or more further research being done. They've actually identified the different T-cell helper class that is involved in the pathogenesis of their IRE. So we decided to do the same thing because it's really a little bit ambiguous with acute interstitial nephritis. While they saw an increase in Th17 cells, we didn't see that, but we did see an increase in Th1 cells. And similar to the other IREs, we saw an increase in cytotoxic T cells. So essentially, I know I've given you a lot of information, but we see chemokines that are associated with interferon gamma as well as a Th1 signature. So we thought, well, is it possible that interferon gamma, is one of the mediators of this pathology? So we looked for an interferon gamma signature, and sure enough, we saw that it was increased in the AIN group. But what I also told you earlier with our Infliximab case series is that there is some evidence for TNF-α or the TNF superfamily members to be involved in the pathogenesis of AIN. And so we wanted to see whether or not there would be a TNF signature. And sure enough, we saw that TNF was increased in the AIN group, as well as the superfamily as a whole. And as I keep mentioning, the development of these IREs are a marker of response to therapy. But are there other markers of response to therapy? I'm going to introduce a new concept now. This is the concept of tertiary lymphoid structures. Essentially, these are lymphoid aggregates that form in tissue of chronic inflammation. So you can see this in tumor, and you can also see it in autoimmunity. So remember, we're still talking about the same, inflammation or inflammatory processes. And what's important about these TLS are that in tumor, if you identify TLS or in a metastatic lesion, it's associated with clinical response to immunotherapy. So the identification of these TLS means that a patient is responding to therapy. And so what is the idea behind that? So when we have inflammatory chemokines such as CXCL9 and 10, TNF, it causes increased interaction of immune cells that then aggregate and form these little lymphoid aggregates that over time, if this continues to be inflammatory, will develop into larger aggregates that then become what appear to be tertiary lymphoid structures. In a mature tertiary lymphoid structure, you'll actually see a germinal B cell germinal center. And so if you think about what B cells do, they produce antibodies, right? So if it's located in tumor, then potentially you have local tumor presentation to these T and B cells, directed anti-tumor killing, but also targeted antibody development from these B cells targeting the tumor cells. And so that is one of the ideas for why TLS is a marker of therapy response. However, we also know that TLS can be seen in autoimmune diseases. So in patients with lupus nephritis, in patients with allograft rejection, actually the development of TLS is associated with a worse kidney prognosis, right? Because we're developing antibodies that are targeting healthy or what was healthy kidney tissue. So again, it's a double-edged sword that we're looking at. But if you look at this schematic here, you see that a lot of the components that are necessary or that are involved in the formation of TLS are the same markers that we saw in our previous analysis. So we see differentially upregulated genes that are associated with inflammatory chemokines, increase in T and B cells, TNF and interferon gamma signatures. And so then we naturally asked, is it possible that TLS is a feature of AIN? So there are several TLS gene signatures that have been published. We first used a very well-validated 12 chemokine TLS signature that has been associated with improved clinical response in patients with melanoma, breast cancer, and I believe also colorectal cancer. And we detected a TLS signature in the AIN group. When we broke down each of these 12 chemokines, we could see that some of these chemokines associated more strongly with the TLS score than other chemokines. And what I'm not showing you is that we further validated this TLS signature using 3 additional gene signatures that are all different, that all showed that there was a TLS signature in AIN. And we went back and reviewed the tissue histology to see if we could identify TLS structures in AIN. And what you can see here is that you have a large lymphoid aggregate. And using CD3 positive T cell stain and CD20 positive B cell stain, you can see that there's a cluster of these CD20 positive cells that are adjacent to these T cells. And so what that tells you actually is that it's not a mature TLS because you don't have a germinal center yet, but it's in the process of developing into a mature TLS structure. And then we go back to the fact that, again, the reason why it's so difficult to understand AIN is that we don't have any non-invasive tests. We don't want to biopsy everyone. We want to biopsy those with inflammatory kidney diseases because we can treat. And so this is where we go back to our paired samples. And with what we identified mechanistically, we simply asked, do the urine and plasma specimens correlate with the tissue signatures? And so we developed customized multiplex chemokine assays to look at these same 12 chemokines in plasma and urine to basically be able to analyze the chemokine levels and then correlate it with what we saw in the tissue. And what you can see here is that plasma actually did not correlate well or really at all to tissue. But we have one more specimen, and that's urine. We did the same analysis and looked at TLS scores in urine, and we saw that there was correlation between tissue and urine, and the AIN group is in the red. But when I showed the heat map, I also mentioned that some of the chemokines associated more strongly with the TLS score, and so potentially we could have a stronger association if we focused in on each of the individual chemokines, and that's what we did next. And when we did that, we saw that CXCL9 actually correlated very well with its tissue level. So urine CXCL9 levels and tissue levels correlated well. And CXCL9 had a very good association with the diagnosis of acute interstitial nephritis with an AUC of about 0.78. But CXCL9 isn't the only non-invasive biomarker for ICI-AIN. In fact, there's a lot of groups out there right now who are doing great work in non-invasive biomarkers research. And the team at Yale identified TNF-α in drug AIN. The team at Mayo reported CRP with retinal binding protein, and they recently also published that urinary TNF-α levels were increased in AIN. And the team at MGH recently also published a paper on soluble IL-2 receptor being increased in plasma of patients with acute interstitial nephritis. So where do we go from here? This is what we're working with right now. We're, if the creatinine doesn't improve, we work these patients up and try to get that biopsy done. But I really think that, probably in a year and a half, 2 years max, we're probably going to have identified, some sort of biomarker that we feel more confident about. And what does that allow us to do? Well, if the biomarker is negative or the level is low, we can say, go ahead and restart ICI therapy, right? You don't have an inflammatory disease. We're not going to give you steroids. But if you have a positive biomarker, high level, we're going to say, okay, you just bought yourself a biopsy. We're going to biopsy and treat, and we're going to move fast, right? Because time is tissue. But what that also allows us to do is it allows us to do what the other organ toxicities are doing, which is restarting immune checkpoint inhibitor therapy, because now we can monitor them while they're on immune checkpoint inhibitor therapy so that if they redevelop acute kidney injury, we can run the biomarker again and decide whether or not this is AIN or if this is some other etiology of AKI. So going back to the case. So remember, this is a patient with RCC. He presented with a creatinine of 7. He was on a tyrosine kinase inhibitor as well as immune checkpoint inhibitor therapy. Creatinine did wonderfully with magic fluids, 3.5 now, and we're stuck here, picking up the service and asking ourselves, what are we going to do? So I don't want to pick on anyone, but if someone wants to, just randomly shout out a letter that they might want to, place their bet on, we can go forward from there. So any takers for A? Okay. Okay. Oh, okay, the hands are going up. What about no biopsy? Let's go ahead and just empirically treat with steroids. Okay, that didn't seem to fly. How about we just continue IV fluids? Patient's doing great. Let's just keep going, because why not stop a good thing? And what if who in here wants to discharge a patient off of service? We're maxed out at like 25 patients. Let's just get this patient off service, and then we'll follow them up in clinic. Anyone? Don't be that bad nephrologist. No, just kidding. Okay, so we obviously got a kidney biopsy, and this patient had very severe acute interstitial nephritis with inflammatory cells infiltrating, the cortical interstitium, just as we would expect from acute interstitial nephritis. And so what you can actually see, which is actually not that obvious, but on the day that he got his kidney biopsy, his creatinine plateaued. And I don't know if that's just a glitch because, immediately after he got his biopsy, we started steroids. So we usually, if we're going to get a kidney biopsy and we have a high clinical suspicion that they may have AIN, we will start steroids within a 72-hour time frame. And thereafter, the patient did really well, and he was actually discharged home with local labs that were faxed into us. So that's it. But really, I want to thank all of the patients and their families, very, very supportive with research processes, internal collaborators within MD Anderson, as well as external collaborators, research team. And of course, this wouldn't be possible without funding and support. So I'm open for any questions. Yes.
Fantastic presentation. Thank you for sharing everything from bedside through your wonderful research. So, question: you've compared or been looking, or you showed us data compared to ATN or hypertensive. What if you compare it to a non-immune checkpoint inhibitor, AIN,
Yeah.
or inflammatory disease, or
Yeah, that's a great question. So we actually have some preliminary data on that. So in patients who are not on immune checkpoint inhibitor therapy, we looked at drug AIN and I think hypertensive nephrosclerosis. And what you end up seeing between ICI-AIN versus drug AIN was that everything was amplified in the patients with AIN from immune checkpoint inhibitor therapy. And in the patients that had a hypertensive nephrosclerosis is very similar to what we saw in our group, which was that there wasn't really an elevation or increase in the inflammatory signals that we detected. But I think what you're, to expand on, I think what your thought is that we need more controls, right? So we need to look at patients at baseline, at resolution, and also not on ICI therapy to really have a great comprehensive understanding of the mechanisms involved and to be sure that this is specific to ICI-AIN. Yes?
I want to echo the comment of Jamie. I love the presentation and congratulations for meeting the basic science training, clinical training, and doing now very high value translational research. So the question I want to ask here is that you showed the therapeutic trial with the TNF antibody before, so there is an interferon gamma signature as well. So someone would say, oh, interferon gamma inhibition could be another approach. So in the treatment, what type of impact has actually on the human progression? Because the challenge is to find really therapeutic that does, what we want to do without really reducing the effects of checkpoint inhibitors. So this is the first question. And the second question that I find in the direction very, very exciting is that you get this toxicity to the patient population that you see at MD Anderson. Do you have access to genetic data? Because there's going to be a genetic predisposition, right? These patients develop
Yeah.
AIN, and it would be very interesting on the tissue-specific manner.
Yes, absolutely.
Myocarditis and so on.
Yes, there is a group there doing genetic analysis. We ourselves are not doing that just because of people power that is necessary to explore all these different avenues. And in regards to your first question about interferon gamma and TNF-alpha, that's a really good question. So the TNF-alpha usage or Infliximab usage in AIN, we don't have exceptionally robust data because what we're looking at is a small cohort of patients who develop AIN and then didn't respond well to steroid treatment. I don't know, and maybe with multi-center clinical studies, if we're able to get the number of patients that get Infliximab therapy, we can then do better analysis on whether or not it has impact on tumor outcomes. We had a case series of 10 patients. Only 3 of them ended up progressing. In regards to interferon gamma, that's a great question. So the colitis team is using interferon gamma, or actually, I want to rephrase that, using interferon gamma early on to see if it helps curve the development of IREs. Now, I think this is still an ongoing research study, so I don't know what those outcomes are, but that is exactly the idea that we're going for, is that we're looking for things that are more specific to targeting the mechanism that hopefully won't be broadly immunosuppressive like steroids are. Any other questions? Yes. Oh my gosh. Okay. Yeah. So my answer is that complements are always involved, but we do not routinely check complements in these patients. The only times that we generally check complements are if it looks like they have some sort of a GN lesion. So in cases of AIN, or if the urine doesn't have a large number of red blood cells or proteinuria, we don't do the full serological panel. but complements are always involved. Yes.
You mentioned that because it was curious to today's so many of these patients, we still look for eosinophils in the
Yeah, eosinophils. I mean, we all know the literature on urine eosinophils, which is literally a flip of a coin. So what I want to say about that is that I think it depends on the mechanism. I think that if you're having a hypersensitivity reaction, you may see urine eosinophils. But if this is autoimmunity, you may not see urine eosinophils. That would probably be where I would guess, but this is just, a very rough guess. Yes? Ah, yes, always. So the answer to that is no. In most of these animal models, what they ended up finding were glomerular pathologies, very similar to lupus, and not interstitial nephritis. There are ways to work around this, but I think it's for me, would be premature to say anything more than that, other than I think one of the things about studying this rare disease is that we need to move backwards, meaning that we need to have a good understanding of the human physiology, which we may be able to with these biopsies, and then work backwards into the animal model there are so many animal models in the nephrology world that I'm sure there is something that is that will be useful, but just not something that that is readily available. Yes. Yeah. I'm not sure if, to my knowledge, there isn't any other literature on TLS in other IREs. But that's not to say that it's not there, because we have to ask, when I read the biopsy reports, there's no mention of this. And so we actually had to go back to pathology and have them look for them, like, specifically. And so that may also be the case for these other IREs, because I suspect that they are there. Okay. Thank you guys so much.